Let's move on to Dr. Sonal Lakdawala. Run along. She's going to present some videos on GRT and PDR.
Thank you, Dr. Karobi, and to the team of AIOC23 for giving me this opportunity. And such stalwarts are presenting here. I think it's going to be quite challenging to put up these cases. Can I have the audio, please? So this is a 45-year-old gentleman who had come to us with a giant retinal tear and phakic patient with a clear lens, didn't want to touch the lens. Went ahead and there was a choroidal detachment associated, so went ahead to do the surgery. So you see the large GRT, and I've kind of all the ports are made, but the infusion port is draining some choroidal fluid, and you can see that I'm nudging and I'm not able to go inside. So I changed the port position, try and put a cutter which I know that is going through, but every time my cannula would go into the subretinal space. Still, the cannula is placed in this position, but when you see the vitrectomy started, a large mound comes in, and you realize the entire cannula is going subretinal. Just to tell you that some patients like these have the entire pars plana off in the area of the GRT, and you're left with nothing but putting a large, long 20 gauge cannula in such patients so that you can stabilize the globe and get your infusion right inside. Once that's done, you put in your PFCL to stabilize your posterior pole like your third hand. You flatten the edge of the GRT. Okay. Is this better? Yeah. And you see the edge of the GRT on the temporal side is quite having a lot of intrinsic contraction, so it's kind of flattened with the help of a soft tip in with the PFCL in place. The extension at the GRT edges were again then lasered, and there was a small retinectomy also done at these edges to flatten the retina very well over there. Initially, because of the GRT, we couldn't see the optic nerve very well in this patient, but eventually the optic nerve was like a morning glory syndrome. So this was the pre and the post op of the patient, and you feel a little happy when you are doing this with a phakic patient and with a clear lens. And such cases where the entire pars plana is off and you're always wondering how to get your infusion cannula inside. My second case is a case of bilateral PDR with a very similar kind of fibrous proliferation right at the disc. And you see the entire prolif just sitting around the disc with completely sclerosed vessels. So, yes, you can pick up the prolif like that also, but I would like to stain it with a blue dye so that I can get an edge. A proportional reflux in the Alcon Constellation machine is very helpful in such cases to create a plane. Important point is to slowly pick up this fibrous prolif, and instead of going from the disc outside, the reverse is taken into consideration. We are going from outside inward so that you prevent more traction in the retina at every point, and then the remaining ILM is again stained, and then the ILM is peeled off. So you have to be very careful in such cases, because in a lot of diabetics you'll have completely sclerosed vessels that you can see on the retina with a very thin atrophic retina, and you do not want to de-roof the macula at all in such cases. This was the post-op of his left eye, and then we went in the same way with his other eye, and you see identical kind of a prolif right at the optic disc. The best is not to peel the prolif completely to the disc, but at the end, once you start peeling from outside inward and you come to the center of the disc, it's important to trim it off at that point instead of trying to pull over the disc and cause more bleeding. The entire retina was very, very atrophic, and all the vessels were extremely sclerosed. So once you come here and once you finish the ILM peel, it's important to trim this off on the disc and not try and peel it further. Sometimes a small part of the ILM can be left at the fovea with like a ILM sparing the fovea kind of a thing, so that you do not de-roof the fovea at all in such cases. Finally, an endo laser is done in these patients and silicone oil is put. Simple surgeries, but if done in a systematic way, I think you can achieve very good results for most of these patients. This was his other eye, and the patient achieved 618 vision in both the eyes. Thank you so much.
Thank you, Sonal. That was an excellent presentation.